Kishan, we can start now.
Yes. Good evening, participants and delegates. Thank you for joining Shield Connect today. So today we have a speaker for the day, Dr. Emrana Rahman, and she is going to speak on the topic recent advances in PCOS. So before we start with the webinar, let me give a little idea about our page Shield Connect as well as introduction of our speaker. So let me share my screen. So this is our page shieldconnect.in, and you can see we have recently won a prestigious award of ISW Digital Health Awards in Women Health Technology Solution category. And this is various sections available in the portal. So the first section is the blog section. So in blog section, you can see we have various blogs available which are written by eminent speakers and doctors. Then the second section is the webinar section, where you can find upcoming webinars and as well as past webinars. So like you can see, if you click on see more for today's session, you just have to register and you will come to this page. And there is the comment section. So participants, you can post your feedbacks as well as your queries in this comment section, so that we can have an Q&A session with our speaker of the day at the end of our webinar. Then this is the past webinar section, where you can find all the webinars that we have conducted in past. So you can go through all this webinar also. Then we have a special awareness pages like PCOS awareness, menopause awareness, immune booster, and COVID-19 update related awareness page. So in first PCOS awareness page, you can get all the videos related to myth breaking tips and tricks from various doctors in different languages like Hindi, English, Malayalam, Telugu. Then the second page recently we have created is menopause awareness page. You will able to find all the episodes related to videos of menopause and blogs as well as. Then this is the respiratory page where you will find all the blogs and videos related to the COVID as well as respiratory immunity. Then the fourth awareness page is COVID-19 awareness page. And we have our leader section page where you can see these are all the eminent speakers who are connected with our page Shield Connect. And we also have a special day page like Hypertension Day, Mother's Day, GDM Special Day, Women Day Special. So if you click on Hypertension Day, you will get all the videos related to hypertension. So this is our page. And now let me go through our speaker for the day. So we are glad to have Dr. Emrana Rahman. Ma'am is currently Director of Fertility Specialist and Endoscopic Surgeon in Janam IVF Center, Taratpur, Bhagalpur. Ma'am was past secretary in IMA. Ma'am is life member of IFS, ISAR, Endometriosis Society. Ma'am is also member of ISSRF. Ma'am has experience in field of on infertility since last 8 years. Ma'am has presented many papers at AICOG, ISAR, IFS. Ma'am has given 8,000 pregnancies of long-standing infertility by fertility enhancing procedures and have numerous IVF babies to the credit. So ma'am, we welcome you on our platform, and I will hand over the session to you further, ma'am. We welcome you, ma'am.
So thank you. Yeah, thank you so much for that nice introduction. And I'm really glad to connect to all of you. Very good evening. So since it's a very common topic and most commonly encountered problem with our patients, but since we are into it and we are discussing this probably with because there are certain changing perspectives and new emerging concepts are there, and regarding its pathogenesis, pathophysiology, long-term implications, and where new chapters are unfolding and which has attracted so many clinical researchers and all over the globe. So we are here just to share a few. I'm there with all of you And I'm really thankful, and it's a proud moment to me, and a very wonderful opportunity for me to be with you. And I hope I would not waste your time and do justice with my deliberation. So let's start regarding the PCO, as what are the recent advances in the PCOS, which just brushing up our knowledge, and let's go about it. So, as we all know, it's not merely a reproductive disorder, but an endocrinological disorder affecting women in their reproductive years. Although hyperandrogenism and infertility that PCOS causes are distressing to young women, its metabolic sequelae eventually plague the individual in terms of morbidity and mortality. As we know that it really plays a great havoc into the lives of female, and they're also much troubled. And so it's crucial to diagnose PCOS early in its course. It's imperative not only to recognize it, but also to delay or arrest its metabolic sequelae. Additionally, screening for the expected complications may allow for proper and timely management of these conditions. Although it is associated with hyperandrogenism and infertility early in life, as we know that probably it is possible that an excess androgen production mm, by the ovary is already genetically determined, and which starts during the intrauterine life. And this results in an androgenic programming of the hypothalamic pituitary unit that favors excess LH secretion. And this excess LH leads to preferential abdominal obesity, and which predisposes to the insulin resistance and ovulation. So this is the new emerging ideas about the developmental origin of the PCOS, where it is supposed to be, I mean, starting right from the intrauterine phase. So there are a lot of evidences are accumulating regarding this, and people have come up. So it's a harbinger of lifelong condition that can lead to serious sequelae such as diabetes mellitus, hyperlipidemia, endometrial hyperplasia, carcinoma and carcinoma, central obesity, sleep apnea, etc. Why should physicians know about PCOS? The diagnosis of PCOS implies that the woman is at increased risk for infertility, dysfunctional bleeding, endometrial carcinoma, obesity, obstructive sleep apnea, very importantly and very commonly type 2 diabetes, mellitus, dyslipidemia, hypertension, possibly cardiovascular disease, especially in our population in India, where there is an underlying hyperhomocystinemia as well, and which leads to more of atherogenesis. And her sisters, daughters, and other close female relatives may also be a risk. She may require lifelong therapy, and find her access to healthcare coverage is limited. So, whenever a patient comes to us, we need to counsel her nicely and take her into confidence, and because this is something that she needs to learn, that it is not going to, unless she goes for a strict lifestyle modification and has to be very disciplined in her life regarding all the her habits and the environment she is in, and she is willing, and we need to motivate the patients a lot, and we accordingly we need to address her changing needs as she grows up. So, because we might pick up any patient right from adolescence to the young, right? Somebody who's planning a reproductive career, and infertility, patients of infertility. So it's really, we need to urge them a lot and continuously motivate them accordingly. Uh, so one of the most common endocrine disorders affecting women of the reproductive age, it is seen in 8 to 11% of the reproductive age group of women, and commonest cause of anovulatory infertility in women, And anovulatory infertility is about 70 to 80% in PCOS, and Indians have the highest prevalence rates in the world. It's alarming and really startling that around 41% in the reproductive age group. So as we can see, the patient number, it is high, staggering high, around 117 million patients, and it's keep on rising, 1 in every 5 women. Just imagine the statistics, and it is around 41% prevalence. And we can know also from the proportion of the patients and the number of patients, almost every 1 out of every 5 patients coming to us is a suspected PCO. As because of the changing lifestyles also, people, it has less of more sedentary styles, more of urban females having preferential the work habits have taken a backseat, and people are delegating things and their household chores as well. And with the genetic predisposition in Indian females, and all are attributed to the sedentary and the food habits also. It is the entire country, and the demography has totally changed, and there is a complete transformation and a metamorphosis which has led to this kind of an emerging burden, which is sometimes, it's as seen as sometimes like the tip of iceberg. So infertility was primary. What all the complications are, we have on the first and foremost, and a very, very common, the women are struggling with as infertility, then obstetric complications, cardiovascular, metabolic, oncologic, and psychological impact, which negatively impacts, and it is a constant stressed females, we find the young girls as well. So the primary infertility was reported in 50% of the women, secondary in 25% of women, and there is an obstetric, there 3 times higher risk of preeclampsia, 3 times higher risk of GDM, 2-fold increased risk in the preterm deliveries, 2-fold increase in the risk of IUGR, so far as cardiovascular complications are concerned, there is an increased risk of MI, and there is a 2-fold increased risk of hypertension. So 5 to 10-fold increase in the risk of developing type 2 diabetes mellitus, another pandemic exposed, and this is one problem which we generally are encountering too very frequently and not expecting too much, but it is sometimes it feels that it is like inevitable kind of a phenomena. Increased risk of endometrial cancer, and a 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, and a reduced and compromised quality of life. So as we go down to the back to the history, and when Steen and Leventhal designated PCOS as a syndrome in 1935, there was, with the advent of a revolution in the gynecological armamentarium, was the advent of an ultrasound. So the ultrasound addition of the criteria came in 1890s, and the Rotterdam Consensus Conference, which to diagnose and to establish and document a diagnosis of PCO, there was a consensus in 2003. And in 2018, there were international evidence-based guidelines for the assessment and management of the polycystic ovarian syndrome in 2018. So there is no universally accepted definition for the PCOS. In 1990, US NIH consensus conference, there were 2 minimal criteria: menstrual irregularity due to oligo or anovulation, clinical or biochemical hyperandrogenism, hirsutism, acne, male pattern baldness, elevated serum androgen levels, above not attributable to other causes. There was no laboratory evidence required for the diagnosis, no radiological evidence required for diagnosis, ovarian appearance not pathognomonic. Uh, Insulin resistance was not included in the diagnostic criteria. It excluded women with other known causes of hyperandrogenism. Diagnosis, it was a diagnosis by exclusion, and there was a lot of clinical heterogeneity, as we all know. Now, what is a typical polycystic ovary? It is defined as an ovary containing 12 or more follicles on using an ultrasound, which measuring 2 to 9 millimeters in diameter, and an ovary that is a volume of greater than 10 ml on ultrasonography with enhanced stroma leukogenicity, and a single ovary, either or both. It's important. It's in an international consensus. So, however, the most important thing that we should remember that it should not be ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years due to high incidence of the multifollicular ovaries in this life stage. So we might confuse with those multifollicular ovaries, and we assign a wrong diagnosis of a PCO in a very young female adolescent age group. So ultrasound is not incorporated into the diagnostic tool. The 2003 ESHRE and ASRM Rotterdam consensus on PCOS requires the presence of 2 out of the 3 criteria: oligoanovulation, hyperandrogenism, clinical or biochemical, polycystic ovaries with the exclusion of other etiologies. As we know, the other etiologies like congenital adrenal hypoplasia, that is enzymatic deficiency, which we know by of 11 beta hydroxylase or C21 hydroxylase, and which is and other hyperprolactinemia, then these things, all these should be excluded before assigning the diagnosis of the PCO. And Cushing should be excluded because other sources of androgen from adrenals, that has to be excluded. So as we all know, these are I've already discussed the long-term implications and the complications. This is how the timeline goes for the diagnosis of the PCO. We have already discussed this. So coming to the etiopathogenesis of PCO, and it's really, it takes little time to understand, and we all know the basic, it is genetics. Now the epigenetics also coming into the, and the lifestyle, all overlapping and all confounding together, and all like acting in synergy to produce all the hormonal imbalances, and particularly exacerbated by obesity, leading to low-grade inflammation, hyperandrogenism, and insulin resistance, and giving a clinical picture of hirsutism, acne, reproductive issues like oligoanovulation, menstrual irregularity leading to subfertility, and a typical metabolic syndrome of impaired glucose tolerance and type 2 diabetes mellitus, and increased cardiovascular risk factors. So how the spectrum of PCOS, it grows from, I'll come to the explanation of that insulin resistance, and I'll try to explain it briefly when I in further slides. As we know that androgen excess is the basic pathophysiology and basic defect in the PCOS, and the triggering factors are the endocrinological dysfunction, metabolic derangement, and enzymatic defect. And it primarily there is a dysregulation of hypothalamic pituitary ovarian axis, somatotropic axis, that means growth hormone as well as all the compartments are affected, and the adrenocorticotropic axis. So this all the axis dysfunction and all the compartments are affected, leading to a higher androgen production, and there is increased pulsatility of the GnRH hormones, which is more of an LH, which behaves more as an LHRH hormone than FSHRH. So there is increase in the amplitude and frequency of the LHRH pulse frequency or GnRH pulse frequency. The peripubertal dysfunction of the LH clock, peripubertal dysfunction of the LH clock, and there are 17 alpha hydroxylase is a common enzyme, cytochrome P450, which exists in the adrenal as well as in the ovarian cortical tissues. And in response to the LH hypersecretion or ACTH stimulation, this enzyme becomes hyperactivated. In addition to this, what we should it's important to understand the fact that insulin acts as a co-gonadotrophin, which may stimulate this enzyme again, and it is a bifunctional enzyme, and this may trigger both androgen and insulin production, and the net effects are hyperandrogenism and hyperinsulinemia. So all are interrelated and correlated. How this excess insulin leads to excess androgen production by two ways: by stimulating LH secretion from the pituitary, and by suppression of sex hormone binding globulin and insulin-like growth factor binding protein 1 at the hepatic level. So, and later IG, insulin-like growth receptor 1 and insulin are structurally and chemically similar. So ovarian theca cells, they have got abundant of IGF-1 receptors, and excess insulin through these IGF-1 receptors, it in the ovary leads to LH-mediated excess thecal androgen production. So this is about the one axis, and I'll come to later to this hyperinsulinemia. I'll try to make all of us share and understand the concept of hyperinsulinemia and how it is disrupting the entire and the panorama of this thing, hormonal disturbances, and is opened up. So the predisposing factors from the childhood, the genetic, I already discussed that there is an in utero programming and of the HPO axis. So, and there is increased AMH levels, which is not there is in the non-PCOS subjects. At puberty, there is a premature adrenarche, hyperandrogenism, increased GnRH pulse frequency, increased AMH levels, and ovarian volume, hyperinsulinemia. Then in the reproductive years, irregular cycles, infertility, subfertility, high antral follicle count, increased AMH, and then increased ovarian volume. However, we cannot isolated in increased value of AMH is not as such have come as a diagnostic tool for we can suspect all those patients with a very high AMH to have a and a very high AFC. We generally know that this is a case of a PCO. Sometimes it might go, AMH levels may go up to 22, 24 even, and the AFC is very, very high in these patients. And the glucose intolerance and insulin resistance. For diagnosing the insulin resistance, however, we have to go for OGTT with a 75-gram glucose load. And if it after 1 hour it is more than glucose is 200, then we diagnose it as apart from other parameters. And there is increased prevalence of hypertension, increased triglycerides. In non-PCOS, there is decreased androgen with age, decreasing AMH, ovarian reserve declines, and the antral follicle count also it goes down with the age. So, in contrast with the as seen in the PCO subjects. So it's important to know the phenotype as well as the lean PCO and the obese PCO, but depending on the BMI. And however, irrespective of the body mass index, insulin resistance is a universal, and hyperandrogenism is a universal phenomena. So we can know that there are 4 phenotypes, A, B, C, and D. In phenotype A, which is common, hyperandrogenism and hirsutism, ovulatory dysfunction, as well as polycystic ovarian morphology, all the 3 are found. In type B, the polycystic ovarian morphology is typically absent. However, hyperandrogenism and hirsutism, as well as ovulatory dysfunction may be there, because the patient may not get their periods or menses even at their very delayed, and even only after induced with the help of hormones, and they are not getting it naturally. It may go to that extent. And phenotype C, the dysfunction, ovulatory dysfunction is absent. However, hyperandrogenism, hirsutism, and polycystic ovarian morphology is there. In phenotype D, there is no hyperandrogenism, hirsutism. However, ovulatory dysfunction and polycystic ovarian morphology is present. So I think most commonly we are getting patients of phenotype A and D with us, and so we need to be really minded for all these phenotypes and have an index of suspicion. So in adolescence PCOS, there is as I discussed, that there is an in utero and there is a genetically predisposed programming of the hypothalamic pituitary ovarian axis and their exposure to the androgens, and leading to fetal testosterone hyperglycemia, hyperinsulinemia, and that determine the PCOS phenotype. So the risk factors 5, what all patients will in future are the potential cases for having a PCOS in adolescence. So there is a family history. They may be overweight, low birth weight, exposure to androgens during gestation. In those with the precocious puberty, obesity, insulin resistance, the diagnosis of PCOS during adolescence requires stricter criteria, and it requires unequivocal hyperandrogenism, ovulatory dysfunction for more than 2 years after menarche. This is important for diagnosing or assigning any patient in adolescence. Ultrasound, we cannot bank one. So the epidemiological link. So just see such startling facts, and I'm really even I was when I was going through the slides, I could come to know that how it is playing a devastating role. It increases the risk of type 2 diabetes mellitus by 1600%, and PCOD increases the risk of gestational diabetes mellitus by more than 200%. So any PCO patient, if treated by infertility, should always be careful that she might develop. And we always find also patient getting into the diabetes mellitus, or we come to know around 5 to 6 months or of pregnancy mostly. and we have to be really careful about it while treating those patients, and have to be strictly observing this thing. So, insulin resistance is present in 65 to 80% of the PCOD cases, and 60% of the GDM patients finally develop type 2 diabetes mellitus. It is said that gestational diabetes mellitus is it's a it's probably it unfolds the future. It's probably a predictor or a harbinger of the diabetes mellitus. Somebody who had a gestational diabetes after a few years, if they are not really having a good lifestyle modification, they are destined to develop type 2 diabetes mellitus in their life later on. So generally, GDM patients, that it unfolds the risk and of type 2 diabetes mellitus. So the pathophysiology regarding that, there has been a considerable debate on what exactly constitutes the PCOS. The key biochemical features present in the vast majority of women are insulin resistance and chronic low-grade inflammation in PCOS. So this is how that insulin resistance, this causes more and more, because the hepatic synthesis of the sex hormone binding globulin as well as insulin like growth receptor 1 binding protein, they are decreased, which makes the more and more testosterone available, more bioavailable insulin like growth factor 1, and more bioavailable estrogen in the periphery, and um, leading to increased stimulation to the ovary. Another, from the LH also, we are getting a stimulation for the hyperthecosis. The adrenals are producing, as I discussed initially, that all the compartments, also somatotropic, gonadotrophic, and adrenocorticotrophic axis, all are implicated in the genesis and hormonal imbalance of, and they are all interlinked and interrelated, and contributory to the genesis of the insulin resistance. And we are having the abnormal GnRH pulses as well, which is, and this GnRH is more of an LHRH than FSH. And so peripheral and target tissues, even the skin is contributing. So there is more and more thicker androgen production, and which leads to the apoptotic and arrested follicular growth in the ovary, and it does not lead grow to maturity, and there is they remain partially mature and finally become either cystic or atretic, contributing to the bulky ovaries and becoming polycystic. Um, and there is a reversal of LH-FSH ratio. Because of the tonically elevated levels of estrogen throughout the cycle for months together, there is a continuous stimulation of the endometrial lining or proliferation, leading to hyperplasia. So all these things. So women with PCOS have intrinsic insulin resistance independent of the extent of obesity and magnitude of the androgen concentrations. Even lean women with PCOS manifest with the insulin resistance. Increasing body mass index, it exacerbates insulin resistance. Normal weight adolescent girls with PCOS have peripheral insulin resistance, increased liver fat, and muscle mitochondrial dysfunction compared with the normal weight girls. So how this insulin resistance it is developing? It is primarily responsible for controlling the insulin is primarily responsible for controlling the LH. Insulin dysfunctioning disrupts the LH-FSH pathways, and there is a hyperandrogenism. So insulin signaling, how this insulin it controls, and so what exactly happens and how it happens. It is because there may be there is a signaling defect, and how this signaling defect actually, because insulin exerts its actions through these glucose 6 phosphate isomer alcohol, which is myonisitol and dechironex, and it acts in the periphery as well as in the central tissues with their high energy utilizing tissues like brain, heart, and ovaries, and in the periphery, liver, muscle, mm, skin, and this signaling is damaged in PCOS cases, and it is driven by the deficiency of myoinositol and dechiroinositol. Women with PCOS, they have decreased sensitivity to circulating insulin irrespective of weight, thus suggestive that insulin insensitivity, that this is quite intrinsic to PCOS. It is innate and intrinsic to the PCOS subject. Insulin mediates androgen production in the theca cells. So, as we know that it is insulin is required for the glucose metabolism, but how this insulin, as there is a defect, and there is a defect in the serine phosphorylation, and the compensatory hyperinsulinemia is associated with the insulin resistant. It provokes excess androgen production and adrenal androgen secretion and decreases hepatic SHBG, sex hormone binding globulin, insulin like growth factor binding 1 synthesis, and the net result is an increased circulating testosterone concentration. This is already, I have already explained. So what makes the PCO subjects different from the normal subjects, normal patients? The answer to this is the paradox of the insulin signaling. What paradox? Why? Because there is as we know that dechiroinositol, it is required, dechiroinositol, and there is a decreased epimerase activity in the periphery. There is in the periphery, by periphery means we mean skeletal muscle, liver, and yeah, and all these peripheral tissues, and the central by means high energy utilizing tissues like the liver, heart, and brain, heart, and ovaries. These are high energy requiring tissues where we need a lot of glucose. So the paradox is they escape this very phenomena of the insulin resistance, and there is an increased epimerase activity at the central tissues, high energy utilizing tissues, resulting into more conversion of the myoinositol, which is there, because we know that myoinositol is converted into dechiroinositol with the help of enzyme epimerase. So there is increased activity of the epimerase at the central tissues and leading to exhaustion of these myoinositol, and they become myoinositol deficient. However, there is a decreased epimerase activity in the periphery, and there is increased dechiroinositol at the periphery, resulting into the hyperandrogenism. So this is the paradox. So where steroid producing tissues and the pituitary retain insulin sensitivity, and this paradox is illustrated by the differences in insulin actions in the granulosa lutein cells obtained from women with anovulation with PCOS. Insulin stimulated glucose uptake is impaired, while insulin stimulated progesterone production is preserved. So this is how the paradox is explained, because we have how it works basically is, I'll come to that slide, and at that time only I'll try to just go briefly and explain it. So hyperinsulinemia, insulinemia associated with high insulin resistance in PCOS. Importantly, numerous genetic and epigenetic factors, non-heritable perinatal and extrauterine environmental influences, and varying adaptations to the nutrient excess likely contribute to the development of insulin resistance and hyperinsulinemia. The prevalence of metabolic syndrome is defined as obesity, hypertension, dyslipidemia, hypoglycemia is approximately threefold higher in the women with the PCO. So altered LH FSH ratio further enhances the hypersecretion of androgens in the Theca cells in the ovarian follicles. The increase in the follicular androgens impairs follicular development and reduces normal inhibition of the gonadotropin releasing hormone pulse frequency by progesterone, further prompting the development of PCOS phenotype. In addition, there is evidence of the resistance to the effects of FSH at the follicular levels in the ovaries of the PCOS women, possibly due to excess local anti-Mullerian hormone production. So there is a dysfunction in the ovarian follicular genesis. The selection of a dominant follicle is abnormal, a consequence of insufficient FSH stimulation and local inhibition of FSH action due to excess local AMH. AMH is a marker or of all those small antral follicles and other intra-ovarian, and it is independent, which is not affected by any feedback of any hormone. So we choose this to be as a ovarian reserve marker. So all those recruitable and small antral follicles, they produce AMH and other intra-ovarian factors that modulate follicular recruitment and growth. Since all the follicles during each cycle, the follicles they get recruited and start growing, remain partially mature and finally become either cystic or atritic or apoptotic. So generally contributing to so this is what happens, and that is why the AMH levels become high and there is no maturity of the follicles, for which we are struggling and by a lot of in infertility and trying to make them mature by the ovulation induction drugs. So the pathophysiological role of hyperandrogenism and the insulin resistance hyperinsulinemic state in determining the PCOS phenotype. Hyperandrogenism is responsible for signs, symptoms of androgen excess, hirsutism, acne, male pattern baldness, skin tax, acanthosis, reduced SHBG, abdominal fatness, and insulin sensitivity, lipid abnormalities. And hyperinsulinemia and insulin resistance are responsible for metabolic syndrome and abdominal fatness, and the cofactor favoring androgen excess, reduced SHBG, and ovulation. So the persistent hyperandrogenism is associated with impaired hypothalamic pituitary feedback, leading to LH hypersecretion, premature granulosa cell luteinization, aberrant oocyte maturation, premature arrest of the primary follicles. So this is how, and all over the place, and we get the patients already stressed with these problems. So the lab evaluations to consider for hirsutism are in an investigation which should be ordered to consider for hirsutism is free and total testosterone. The only investigation needed in most cases, gonadotropins, LH and FSH ratio is reversed. LH is more twice or 4 times than the prolactin. It is raised in patients with prolactinoma and taking certain medications. 17-hydroxyprogesterone, it is raised in congenital adrenal hyperplasia more than 350 micrograms. And dehydroepiandrosterone, which will be raised as a marker of adrenal tumor. And thyroid function tests, we all generally subject to these battery of tests to exclude the other contributors of the high levels of the androgens. Impaired glucose tolerance and diabetes mellitus. Of obese women with PCOS, 10% have undiagnosed diabetes and 35% have impaired glucose tolerance. So Dunaf Dunaf et al. He researched around the mechanism and implications of the atherogenesis, almost the lipid profile and the PCOS, how it is affecting and how it is disrupting. That is almost 70% of the patients with PCOS have an abnormal lipid profile, high triglyceride, low density lipoprotein, and cholesterol are often found. This was found by Dunaf, and this predictor and prevalence and predictor of dyslipidemia in the women of PCOS. This I think I've already discussed. So we know that what is this myositol? It is one of the isomeric structure of inositol. Why? What inositol? Both these inositols, insulin mediates its action through these inositols, utilizes this inositol to exert its action of glucose utilization in the body, and it occurs as secondary messenger for insulin, transferring insulin signal to the ovary. Mannitol, it transfers insulin signal to ovary. It acts as a secondary messenger in follicular growth, and it is transferring of pituitary hormonal. It helps in transferring of pituitary hormonal signals. So mannitol, it helps in normalizing LH-FSH ratio, thereby it reduces androgen production by the theca cells, maintain hormonal balance. It helps in follicular development by acting as a secondary messenger. It helps in oocyte maturation and quality by calcium ion oscillation. So the treatment aim of the mannitol is to restore the cycle fast, reduce androgen level, overcome insulin resistance, and improve oocyte maturation and oocyte quality. So this is a new kid, not all that new kid on the block, because we have been using perhaps quite a decade. I think it has been launched, and no more prevalent in its use. Many a times when patients with metformin, they have but sometimes side effect profile is more, and in those cases we generally prefer this myoandidicarbonate preparation, though where it is in gastritis or the patients with the diarrhea where we are intolerant to the metformin, then in generally those cases we particularly very young patients or patients with the lean PCO patients who they are really benefited out of it. And even the patients which are intolerant to the metformin, because we need little change, because we have been using metformin since more than three decades, and we perhaps I personally on my level have found very comparable results with these inositols even, which I found it little, I mean, it was difficult to convince myself, but when I started writing the prescriptions of this, and it really worked wonders, and it's a magic molecule so far as PCOS are concerned, and almost comparable results as that of metformin. So myoinositol and D-chiroinositol combination in the treatment for obese PCO patients with BMI more than 25, insulin resistance is very high, and D-chiroinositol is excreted 6 times more through urine. Epimerase is an enzyme which converts myoinositol into D-chiroinositol, and the epimerase enzyme activity is very high with hyperinsulinemia at ovarian level. As a result, it gets exhausted, and the entire, it is going on converting. Myoinositol is exhausted, and it is converted into DCI and leaving in deficient state of MI. And so the physiological ratio of myoinositol and D-chiroinositol is 40:1, and this gets disturbed and disrupted. So there is a poor glucose uptake and utilization. and insulin is not utilized, leading to hyperinsulinemia. At the periphery, that there is a decreased epimerase activity where the D-chironositol is preponderant, and D-chironositol, it is not converted into myoinositol, and so there is more of the which is responsible for the glycogen synthesis, and this is at the level of the liver skeletal muscles, and to clear the glucose, and more it is MI is not found in the periphery. So a deficient state of because of the decreased epimerase activity, and there is hyperinsulinemia and hyperphagocytosis and hyperandrogenemia. Ovary is high DCI and low MI, and the reverse is found. This is the paradox between the PCO and non-PCO subject, that in the we get a normal physiological balanced ratio, and in the ovary they have high DCI and low MI. In the periphery they have high MI and a low DCI. Where what is required is just reversed. An ovarian function disturbed due to low MI, because for the final maturation and follicular oogenesis and the final intra for ovarian signaling, and it is carried out through the calcium ion oscillation and all those by myoinositol, and myoinositol alone is not enough in obese PCO. So we know that it improves MI-DCI ratio 40:1, benefits in obese patients. How it benefits? By restoring the menstrual cycle, improves hormonal metabolic profile, improves oocyte maturation and quality, improves embryo to grade 1, top quality embryos, better M2 sites on fertilization, when it can act as improving the oocyte quality, and so before even IVF, generally it's a very preferred molecule as an adjuvant in all those poor responders. Increase sex hormone binding globulin, reduces androgen level, reduces very high insulin resistance fast. So the evolution, how of PCOD, to summarize, the genetic, environmental factors leading to inositol deficiency, and there is a deranged insulin signaling in the form of receptor substrate complex as the insulin forms at the level of the cell. There is a post receptor signaling is affected, defective serine phosphorylation, and PI3 kinase, it binds to PI3 kinase and further to glucose, GLU, GLUT4, and which acts as a safety guard, and which opens up the channels to take the glucose inside the cell. So there is a deranged insulin signal, and the pituitary dysfunction, enhanced ovarian androgen production and development of the insulin resistance. So the clinical hyperandrogenism, how it manifests as hirsutism, we all know, very, very common as hirsutism, acne, seborrhea, male pattern balding, increased muscle mass, deepening voice, clitoromegaly. So insulin levels may be increased in the majority of the patients. How we diagnose a fasting glucose to fasting insulin is simple and effective way. Ratio of less than 7 is suggestive of hyperinsulinemic state. Fasting serum insulin above 15, serum insulin levels after 75 gram glucose load more than 25 can suggest hyperinsulinemic status. So both fasting serum above 15 and fasting serum insulin level after 75 gram glucose. Generally, we don't do this. We just go for the common behavior by all of us and by most of gynecologists is we write fasting serum insulin, and we write a glucose insulin ratio of less than 4.5. And we generally give OGTT after 75 gram glucose load. This is our common investigation writing behavior. And we generally, personally, I don't give this serum insulin post 75 gram glucose load. However, if it is above 25, it's pointed towards an hyperinsulinemia. So infertility, we all know when all these patients were trying to get pregnant and they land up might into multiple pregnancies and miscarriages, um, pregnancy-induced hypertension, preeclampsia, 3 to 4 fold increased risk. The first line improvement is to go for a lifestyle improvement. Obese patient, even 10% of the weight loss of the BMI, changes in diet, physical activity is highly recommended. And weight loss itself decreases serum insulin. So all we need is a vehement motivation of all our patients, and rather to run a weight loss clinic. We can urge, and we can also, and than resorting to any form of most of the medications they might not need to, because the weight loss itself reverses the entire pattern and the scenario of hyperinsulinemia, and her menses are restored, the cycles are restored. She may start ovulating on her own. So many patients, if they have cut down on the weight, they don't need us probably. They don't no need any clinician or the gynecs if they are having a beautiful and disciplined lifestyle. So the weight loss decreases serum insulin androgen levels, reduces the risk of glucose intolerance and type 2 diabetes mellitus. Pharmacological interventions in the presence of insulin resistance and glucose intolerance or dyslipidemia that persist after even after lifestyle modification, they are unable to curb onto it, they are unable to do it, or strict and are not yet very much committed to it, and difficult to find themselves tuned to it. Then in those cases we need a lot of interventions. We need to always impact and intervene on them. So the treatment strategy, so current armamentarium, the first and foremost is insulin sensitizer in the form of metformin, then these inositols, then anti-androgens. We have this, we cannot go for those patients with infertility who are planning pregnancy, because all are androgenic and may have a teratogenic effect, so they cannot be given simultaneously. All spironolactone and flutamide, finasteride, and sapropteron acetate. It can be given in isolation for those patients who are typically coming with the complaints of hirsutism, and we are targeting only that problem. Oral contraceptives also that really helps. Ovulation inducers like clomiphene, letrozole, and anastrozole. Cosmetically, it's important that nothing is going to work. We must ask them for, but permanently it is the laser hair and can bariatrics, acne therapy, and for laparoscopic ovarian drilling has got a role in subset of the patients, especially for that lean PCO who are at higher risk of developing hyperstimulation, and they may be, and who cannot be under really follow-up while planning an infertility, and was going to start their obstetric career, and they are starting or embarking on to planning their pregnancy, and before any fertility treatment, they may really benefit out of it with the laparoscopic ovarian drilling, because and they were not available for the follow-up also very frequently. So all how to manage all those menstrual disturbances who no wish to conceive, medical therapy for interruption. So we can give OCP. However, it increases the risk of cardiovascular disease, dyslipidemia, and thromboembolic events, increases the risk of type 2 diabetes mellitus with OCP, which is dose dependent. A low dose oral contraceptive pill is recommended. And So fertility treatment options in PCOS. We have international based guidelines. We have an algorithm, an assessment of treatment of lifestyle modification first and foremost, reducing weight and maximally motivating the patients and urging them for the reduction in the BMI. It should be constant and persistent, and if we fail in that pursuit, then we may resort if her pattern of bleeding and ovulation can be restored in few of the subjects by simple lifestyle interventions and discipline. However, for planning, then we have letrozole is considered as a first line therapy. We have clomiphene, we both clomiphene and metformin, and then if it failed to ovulate, then we can add gonadotropin. Second line is a therapy is gonadotropins and laparoscopic ovarian drilling, as I've already discussed. And third line, if it fails to do and fail to achieve by this chronic slow dose step up protocol can be good option with the gonadotropins, and we need to follow with the ultrasound and do a good trigger and can use an IUI. So that, of course, is an entire that's a different deviation from the subject on if it fails then an IVF. So letrozole should be considered as a first-line pharmacological treatment for ovulation induction in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth. When letrozole is not available or use is not permitted, in India, we have been permitted with a 2.5 milligram dose, I think, and letrozole is well used by us. Clomiphene and metformin for anovulatory infertility in obese, BMI above 30, clomiphene is preferred. In obese, BMI very high, combination of clomiphene, metformin other than metformin alone. Why the metformin? It reduces all those parameters. Hyperandrogenemia reduces insulin. It is a very good, great sensitizer. Gonadotropin is a second line of treatment for ovulation induction, and it has to be used in the clomiphene resistant patient, and along with metformin, it really gives good results. So laparoscopic ovarian surgery should be second line therapy for the women of PCOS where clomiphene resistant, who are clomiphene resistant with anovulatory. It should potentially be offered as a first-line treatment if laparoscopy is indicated for any other reason in women with PCOS. Sometimes we need to carry out a tissue lysis for other tubal factors as well with anovulatory infertility and no other fertility. There might be in previous AMH level should be done preoperatively, and there are certain chances, if not done meticulously, however, that that may be a decline, and there may be sort of maybe decline in the ovarian reserve. However, we go for a 40-watt setting at 4 places, the anti-mesenteric water. We all know this, and we have been doing this, and it really, because the thecal the load of androgens is really by the medical treatment, it might take a long time, and this really there is a normal resumption of the ovulation, and the patient responds very well after LOD. And if we are doing going for a laparoscopic ovarian dysfunction, and it reduces the dose for the gonadotropins and other adjuvants. So bariatric surgery, new kid, not very prevalent. We have to really pick and choose and be cautious about it. Should be considered an experimental therapy in women with PCOS for the purpose of having healthy baby, with risk to benefit ratios currently too uncertain to advocate this as a fertility therapy. Cost is high, and there is a need for the structured weight management program, diet, which involves diet, physical activity, interventions to improve psychological, musculoskeletal, cardiovascular health to continue post-operatively. Perinatal risk such as small for gestational age, premature delivery, possibly increases infant mortality, potential benefits such as reduced incidence of large for gestational age fetus in GDM, recommendations for pregnancy avoidance during periods of rapid weight loss for at least 12 months after bariatric surgery with appropriate contraception. If pregnancy occurs, there has to be strict monitoring pre and post-operative nutritional deficiencies, and the fetus has to be closely monitored during pregnancy. However, not it's recommendedly routine, no, yet to be, it has to be considered for a routine recommendation. IVF, recombinant LH not to be used routinely with FSH. GnRH agonist protocol preferred over agonist, reduced duration of GnRH antagonist protocol has to be preferred over agonist because of the reduced duration of it. There's a typing mistake probably. Because of reduced duration of stimulation and decreased dose and cause, decreased ovarian hyperstimulation. And there is a just trigger, and we can freeze all the extra embryos, and it can be the endometrial glandular dysynchrony is not there in the freeze-all cycle. There is no more closure of the window of implantation, or so that is we consider elective freezing of all the embryos. So we can, it is more favorable for implantation, and we have OHSS free clinic in the case of antagonist protocol when we use, and we are more comfortable, and we can batch also more, and if we go for the reduced duration of stimulation, and we get after a good agonist trigger, when we use GnRH, it is more physiological, then we get good M2 sites can be seen and good top quality embryos. So now the inositol in PCOS, which is the new kid in the block, and as since time immemorial, we have been using metformin. So how it behaves better or comparable or superior or inferior, let's discuss this a little bit. So the inositol, there is an insulin signaling. Insulin receptor resides in the cell membrane. So the insulin binds, finding insulin substrate complex. With its beta subunit is phosphorylated by insulin. Insulin receptor substrates are activated. So for P13K, docks to the insulin receptor substrate complex, which then leads to phosphorylation of the phosphatidyl inositol, eventuating into insulin inaction. So this myonisitol increases insulin sensitivity by making more phosphatidyl inositol available. Both MI and DCI levels are very low in PCOS compared to the normal subjects, where the normal physiological ratio, as I have already told you, is around 40:1, but the therapeutic, but PCOS is a pathological condition. So the therapeutic doses which are required in the PCOS subject, it has to be a DCI of around 300 to 600 milligrams and a myonisitol of 2 grams. So this is the therapeutic dose. So there are a lot of formulations available, and like combination, so many, it's all flooded, most of the pharmaceuticals, but this is a therapeutic dose. And so fertility is restored, how, because the insulin signaling is normalized, insulin resistance is diminished, insulin levels become normal with supplementing MIDC in this ratio of 40:1. Inflammation of ovarian theca cells come down, androgen levels come down to normal levels, menses become normal, and the fertility is restored. So the Cochrane database library also, there's a forest plot which says that is a high p-value, it is significant, and anisotol versus placebo and no treatment, there has shows an outcome is better outcome with anisotol with a p-value with a good significant p-value. So to conclude, PCOS is a multifaceted condition, a multidisciplinary approach for subfertility, and an ovulation is required. Holistic care to increase success rates of fertility treatments, lifestyle modifications like diet, exercise, behavioral therapy are principal treatment. Low-dose gonadotropins can be used as the first-line agent when affordability and accessibility are not the major issues. IVF is indicated when previous interventions fail in tubal occlusion or other male factor as an adjunct. So thank you so much for the patient hearing.
Thank you so much, ma'am, for giving all this important information regarding PCOS. Now, let me check if we have any queries in the comment section. So please wait for 1 minute.
I think there are no more participants. I think it has to go on. If it goes in the YouTube, maybe not many people have joined because of the less homework, as I already told you, whether it is going a waste of the monologue, because I think it needs little bit a 10-day workup for the people to make aware, and suddenly because of their own reservations or the workload and all, their own engagements, people will not be able to join. It's very difficult to invite. Invitation has to be done, it has to be executed beforehand. And this is my, if it has been recorded, it's okay. I thought if it is recorded, then maybe I go ahead with it. There's nothing in the chat box, I think. Hello, am I audible?
Yes, ma'am. Nishant?
Because it was a festive season and I think we have chosen a wrong time for this.
No, ma'am. We have good questions. I'll just try to contact Nishant. Nishant?
Yeah. Oh, sorry, I was on mute.
Ah, yes.
Yeah.
No.
Okay, I was continuously going on, but was not able to. Okay, ma'am, I had one question from my end. How much prevalence is there of eating disorder for PCOS in young girls?
Young girls as such, they have a lot of eating disorders, because I think it's very important to lifestyle modification is very, very important, and they have more, there's a lot of eating disorders, and it has their entire lifestyle is so very erratic. And because people, I mean, the girls, these have mobiles with themselves, and the entire scenario of the habit of doing work and even the domestic woes have changed, not even in the urban population, even in the rural areas. So this is all due to, maybe due to the use of mobile phones and all, and they have got a sedentary lifestyle. So that induces obesity. So once the obesity is set in, it is very difficult to curb the appetite. So I think you should more focus on some brand, because the Shield have got some very wonderful brands that is there. And so we should focus on the brands like which would curb, which should be anti-obesity, because what we are really impacting is the BMI. Leave alone the lean PCO. I'm not talking of the lean PCO, because irrespective of the BMI, even the lean PCOS have the hyperandrogenism. And even the obese, so hyperandrogenism and hyperinsulinemia is common in the lean PCO as well. And your brand is really effective, but I would urge you people to bring something that could be a revolution, like whatever brands Shield have right now. It has to be a revolution in the weight management program without a significant side effect profile. And it has to be really compatible with the so that, because whatever, we don't have any drug right now that will really impact on the weight, and that is going to curb the weight excess for except for the uh, activity or the physical exercise which we advocate to all our patients. But we don't have any drug, and people want something really very fast, and they want something really magic to be done to themselves by just eating and popping a pill. They don't want to resort to activity or something like that.
Yeah.
This is the newer mindset and the change mindset, because it has happened, and now it is people, the young girls, they're habituated to these things. They're less of work and less of activity, and because we have everything which is mechanized and everything, and that deters them from this. Even after marriage also,
Yes.
they're doing less work as compared to, like, we people in our young days used to do everything. But now when you find that they're not doing that much of domestic chores
Physical
or any
works.
other chore,
Yeah.
they're less active.
Yeah.
Rather than doing the domestic chore, what people are doing, they are going to the gym, which is not required. I mean, okay, fine, but everywhere, every all, and this is something which is really penetrative, this phenomenon of PCOS, and even in the rural areas, they have got this problem. From where you will get a gym? So what is the need of the hour is something like, even this liraglutide, I hope it should come as a recommendation in the weight management or obesity. It really does wonders to the weight. It good control of weight, but it is not a routine recommendation, and it is very costly also. This GLP-1 analog for curbing onto weight. So what I ask you people, because all the formulation from your side, like Stro G100 or anything like this is all kind of a herbal medicine.
Yes. Yes.
So I want a good herbal medicine to be brought by you people, good researchers to be done on that, that will really curb onto weight, and which acts as a magic pill, and that will help the problem go away,
So,
and melt down the fat. Something a
right.
fat melting pill is really need of the hour, because
Yes.
once the weight is lost, um, much of the, just by the I think by lifestyle modification, half of the problem is solved. But there are certain lean PCO we cannot help. They have really to be helped, because with the drugs itself, because they are lean and still they are PCO. So there, that is a different phenotype. So as I told you, uh, I don't think people, I was really skeptical about the viewership, and not people have joined much. Uh, and I'm really, if it is taken onto the YouTube, and you people have given me a lot of confidence regarding this, and I was
Yes, ma'am.
really
We will send the link of YouTube, as well as at the end of the session, we do get the Excel sheet of list of the participants that have joined the
no,
webinar.
no. These are the participants from my own people. Whatever. I don't think many people
Like
have
this
joined.
is the speaker link where these 3-4 people have joined. The other link is there, the delegate links where other participants are joined. So we will send that information to you.
Okay. Have you recorded everything now?
Yes, 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 ma'am.
Okay.
Thank you so much for giving
Thank
all
you.
this information on PCOS. And yes, we will definitely work on something regarding the weight management regarding product.
I think
It will
that
be
is very
helpful.
much
Yeah.
required, and I really expect this from a company like Shield.
Yes, yes, ma'am.
And thank you for
Yes, ma'am.
giving me this opportunity.
Thank you,
And
madam.
okay,
Even we
I
would like to have more sessions with you in the future. And thank you, delegates, for joining for today's webinar as well. Thank you, ma'am.
thank you.
Bye.
Would delegate